When we talk about ABGs, we are looking at how the body regulates acid and base in the system. That is basically what acid-base imbalances are all about. It's just like electrolyte imbalances. What happens to potassium? What happens to sodium? What happens to chlorine? And all the other electrolytes we have. Similarly, when you take acid and base, the body needs acid. As we know that when you take the GI system, we have hydrochloric acid there, which plays a very key role when it comes to body metabolism, when it comes to metabolism. Same thing applies to what we call base. The body also needs base, but you need to have what we call a balance between the two. Okay. At the point when one is higher than the other, it leads to some form of abnormality. And at the point when the other one is also high, it also leads to up. So the body has to have what we call a normal acid or base in the body. If it goes up or it comes down, it becomes abnormal. And so when we talk about acid base, we all know that we are looking at hydrogen ions from our basic chemistry. We are not going to go through this, but just for you to understand, the NCLEX is not going to bother you on this. We'll look at what the NCLEX will ask you more. But for us to understand what acid is, what a base is, and then the normal levels, we all know that from our basic chemistry, acids are formed from what we call hydrogen ions. And so the hydrogen ions determines the body pH. Okay, it determines what we call the body's pH. And we know that from basic chemistry, we say that normal pH is between 0 to what we call 14, right? From basic chemistry, we say that pH is between 0 to 14. 7 being neutral. If you did science in, JHS or high school, you know that when we say the pH is 7, it means that it is neutral. That is for chemicals and all that in terms of chemistry. But when it comes to the body pH is different from the normal pH that we know in chemistry. And so when it comes to the body, we say that the normal pH of body fluids is between 7.35 to 7.45. For this, everybody here, and I believe that everyone here understand or knows that the normal body pH or body fluid pH is between 7.35 to 7.45. Whether it is urine or whether it is blood you are testing, the pH is, regardless of the type of body fluid you are testing, whether it is blood, whether it is vaginal fluid, whether it is urine, or whatever type of body fluid you are testing the pH, it has to be between 7.35 to 7.45. That is the normal range for what we call body fluid pH. Then when you take, so I said that the hydrogen ions give us the pH, or it determines whether the body is acidic or it is alkalotic in nature or it is a base. So depending on the number of hydrogen ions in the body, we'll say it will determine whether the body is acidic or the body is a base. Okay, or the fluid is a base. So when you take acids, we know acids in the body mostly comes about as a result of metabolism. After you have eaten most of the food, end products of foods like protein will ends up in producing what we call amino acid, as we all know. And so acids are produced as end product of what we call metabolism. They contains hydrogen ion. And so acids are predominantly more of hydrogen ion. The higher the number of hydrogen ions in the body, the higher the acidity. And so if you have high hydrogen ions in the body, it means that that very situation or that very fluid is likely going to be acidic. And so let's say you take urine and then you have high hydrogen ions in the urine. What it means is that the probability that the urine is going to be acidic, as we all know that urine is acidic in nature. And so the higher the number of hydrogens ion, then the higher, acidic or more acidic the substance will be. It is considered hydrogen ion donors. I don't want to bombard you guys with all this. They give up hydrogen ion to neutralize or decreases the strength of acid to form a weaker base. So these are just, chemistry. I don't want us to worry ourselves a lot. But what I want you to understand here from this slide is the normal body fluid pH, which is between 7.35 to 7.45. Acids are predominantly as a result of what we call body metabolism. After we have metabolized most of the foods that we eat, we end up producing what we call hydrogen ion, and that causes the fluid, or that leads to what we call acid in the system. Then when it comes to bases in the system are mostly as a result of what we call bicarbonate level, or the number of bicarbonates in the system determines whether our body fluids are alkalotic or it's a base in nature. When I say I will be interpreting alkaloid and then base together because they are the same. So sometimes I might use alkaloid. At times too, I might use base. So bases or alkalotic or alkaloid are the same. And the same thing applies to acids and then acidosis. So if I'm saying acidosis, I mean acid. And then when I say alkalotic in nature, I mean a base. Okay. And so we said that hydrogen ion leads to acid, right? When you have more hydrogen ion in the system, it is likely that the body system is going to be acidic in nature. And same thing, we are saying that base is predominantly of bicarbonate. And so you don't expect that if a substance is alkalotic or basic in nature, you don't expect that substance to contain more of hydrogen. No, because hydrogen ion will lead to acid. So bases contains no hydrogen ion. Hydrogen ion, they are hydrogen ion acceptors. So they accept what we call hydrogen ion in order to what we call neutralize a system. Okay. Normal serum bicarbonate level are 21 to 28. So for the purpose of the NCLEX, I thought I did these changes. So you see that the second one, I did that one, the millimole per liter. For the purpose of the NCLEX, let's take let's take bicarbonate levels to be 22 to 26. That is what I know everyone here knows. That's the
Sir, your
normal.
voice is low. I don't know if it is
My
my
voice
end
is
here.
low. Have you tried?
But I
Have you
can't hear
tried
you.
your speaker? Is it to everyone or hello? She says my voice is low. Is it to everyone?
No, I am fine. Yeah.
You are fine. Then kindly check your settings, okay? Your device volume. Kindly check it, okay? It might be from your device volume, okay? All right. So I am saying that for the purpose of the NCLEX, okay, let's take base, or yes, let's take the normal bicarbonate. Let's take the normal bicarbonate level to be 22 to 26. Okay. In some books, when it comes to lab values, you might see one or two things. And so here, let's do it 22 to 26. Okay, that is the normal bicarb levels. And bicarbonate itself is considered as alkaloid in nature, or is considered as a base. And so if you have more what we call bicarbonate in the system is likely going to be alkalotic in nature, or it's going to be a base in nature. Okay, that is what I want us to understand from this. And so in base, we don't expect to see more of hydrogen ion. Bases are more of what we call bicarbonate in nature, And so the bicarbonate will lead to what we call the system becoming base or basic, okay, or alkaloid. Then we go to how the body regulates what we call the regulatory systems for hydrogen ion concentration in the blood, or how this acid and base are regulated. Okay, we know that the body uses the buffer systems. I wouldn't go much into it, but what you need to understand is that the body uses the buffer systems to regulate acid and base. Then these two organs, we'll talk more of the lungs and the kidneys, because that is where the NCLEX will talk more of, will let you understand that what will happen when one is not able to breathe well and the person is keeping more carbon dioxide in the system. What happens to the body? And so two body organs that plays very key role when it comes to regulation of acid and base are lungs and the kidneys. We know that the lungs helps with regulation of what we call carbon dioxide. It brings out carbon dioxide and then takes in oxygen. And when we get to the main issues, you get to understand that carbon dioxide is considered as acidic. So if you have more carbon dioxide in the system, it mostly leads to, or it leads to acidosis. And so the lungs helps to regulate acid and base by maintaining carbon dioxide in the system, depending on what the state is. And so if the lungs realize that the blood is more of alkaloid, it's more of a base, it retains what we call carbon dioxide, so that the carbon dioxide, which is acidic, will then neutralizes what we call the base. The same thing, if the body is more acidic, the lungs can regulate what we call the system by bringing out more carbon dioxide, which is acidic in nature, so that the body will now, or the acid-base balance will now be maintained. So the lungs plays very key role when it comes to acid and base imbalance. So for the purpose of the NCLEX, we need to understand that one organ that play very key role is the lungs in terms of acid and base imbalance. Then we have the kidneys. So the kidneys, as we know, I was saying that urine is predominantly acidic in nature, right? So, or urine, when you go and test urine, you are likely going to realize that, I mean, when you do your ABGs, the urine is more towards the acidic way, okay? So kidney also helps to bring out what we call waste products. And so if you have more acid in the system, the kidneys can excrete what we call the acids or the hydrogen ion through urine. The same thing, if the body is lacking acid or the body is lacking hydrogen ion, the kidneys can also work to retain what we call the body can retain the hydrogen ion and then neutralizes the alkalotic nature if the body is alkalotic in nature. So kidneys play similar role, just as the lung will also play, by regulating hydrogen ion levels. Okay. Then when you take another thing that also helps to regulate hydrogen ion is potassium. We know what potassium is. Potassium is an electrolyte. And so potassium will not remove, hydrogen ion from the body as the lungs and then the kidneys will do. But what it does is that it exchanges with the hydrogen ion. And so we know that when we talk, we have extracellular fluid and then we have the intracellular fluid. And so the blood is more of the extracellular fluid. And so if you have more hydrogen ion in the blood, the potassium, which is in the cells, can move into what we call the blood and then push excess hydrogen ion into the cells. And then it will help neutralizes what we call the blood. So I said what potassium does is that potassium comes into the blood and push excess hydrogen ion into the cells. And then it will help neutralizes what we call the body system in terms of the number of hydrogens ion in the body. So this is how lungs, kidneys, and that of potassium, as well as buffer systems, works to regulate acid and base imbalances in the body. At least for the purpose of the NCLEX, what we need to know that the lungs and that of the kidneys, they are the major organs that helps with acid and base imbalances, and then how potassium also works to regulate what we call acid and base. If you have any question on how the regulatory, factors or the systems that regulate what we call hydrogen ion, you can also ask. And so like I said, I'll be doing more of the talking now. When we get into the main work, you come in and then we do the work. Okay, for now, we have to build the understanding. Now, we are now coming to where we need, what we actually need for the purpose of our NCLEX. And so let's talk about the main issue. So we are starting first with respiratory acidosis. Now, let's get the foundation from here, or the understanding. And so respiratory acidosis. First, I talk about the lungs, how the lungs work to regulate acid and base. And so when we say respiratory acidosis, it means that the body or the blood is more acidic. But the reason or the cause of the blood becoming more acidic is as a result of a respiratory problem. It means that the respiratory system is not working adequately to get rid of what we call acid in the system. And I told you that carbon dioxide is what is considered as acidic in its natural form. When you have more carbon dioxide retaining in the body, what it means is that the system is more likely going to be acidic. Okay, so we are looking at respiratory acidosis. And I'm saying that respiratory acidosis, the problem is coming from the respiratory system. The lungs are not working adequately to get rid of carbon dioxide. So the system is retaining more carbon dioxide, leading to the body becoming more acidic, or the blood becoming more acidic. So we'll now look at conditions. So whenever you get respiratory acidosis, think about conditions that will cause the body or the lungs not to be able to bring out carbon dioxide. So think about asthma, that when someone is having asthma, the person finds it difficult to breathe. And so the person is not able to bring out carbon dioxide, and the body retains excess carbon dioxide. So whenever you get a question, the question is about respiratory acidosis. Think about conditions around the lungs that affect gaseous exchange. And then you are going to get all your answers correct. So when we talk about respiratory acidosis, we mean the total concentration of, buffer base is lower than the normal, with a relative increase in what we call hydrogen ion concentration. That's a greater number of hydrogen ions circulating in the blood than can be absorbed by the buffer systems. And so it is acidosis. And so we say that acid is determined by the number of hydrogen ion in the system or the body. And so if someone is having a respiratory acidosis, what it means is that the individual is having more of hydrogen ion than base in the system. That is not what the NCLEX is going to ask you. What the NCLEX is going to ask you is, what are the causes? And so causes of respiratory acidosis are primarily when there is a defect in the lungs, or when the lungs are not working adequately to be able to bring out carbon dioxide, or changes in normal respiratory pattern. And so if someone gets a respiratory condition, and as a result, the person is not able to breathe adequately or is not able to breathe normally, or the breathing pattern is affected, the person tends to retain more carbon dioxide, and that leads to more hydrogen ions in the blood, and that leads to what we call respiratory acidosis. And so any condition that causes an obstruction of the airway leading to hypoventilation. When we say hypoventilation, the individual is not able to breathe well. So respiratory pattern reduces. Okay. And so when the respiratory pattern reduces, the body is not able to bring out carbon dioxide, or depressed. When the respiratory system is depressed, they can cause what we call respiratory acidosis. So let's look at the conditions. At least we need to know them. And so we have asthma, which is the first one. And so if an individual is having asthma and they are asking you which of the acid-base imbalances you expect the person to experience, first, understand that we are talking about a respiratory condition. So don't go and mention metabolic. The moment you hear asthma, and then the options you have metabolic in them, cancel those ones out, and then come to the respiratory ones, because you know that respiration. Yes, Madam Benis, your hand is up.
Boss Amingo, I was wondering whether you could change your background a little. I don't know if I'm the only one having the problem, as if I'm not seeing well.
You
with
cannot
the background.
No. Okay.
If it's possible,
Right.
if not, it's okay. But if it's possible.
Okay. I have to do a whole, that would be a very big. But let's see. Is it Madam Benis alone who is having the challenge, or we are having the challenge? Hello.
Which
Let's
challenge? See you or
Madam Susanna, can you see it well?
yeah, I can see it well.
You can see
Sir,
it
please,
well.
can you change it for us?
It's going to. That will be. Oh, I thought. It will be a whole lot of work. That's why I am. So if you guys can, I don't know if you can manage with it for me today, so that next time I won't use this background again.
Okay, we'll manage, but you buy a space.
Okay, sorry for that. It's going to be a very hectic work if I'm to change the background now. It means I have to work on the whole slides again. So pardon me for today. I will change it the next time. So I was talking about conditions you see respiratory acidosis, right? And so we are looking at conditions that causes the respiratory system not to be able to work or function properly, leading to retention of carbon dioxide in the system. And so first of all, we know asthma. Asthma, you have the bronchioles, right, getting constricted, and then as a result, gaseous exchange is not able to occur. And so you have the person retaining more carbon dioxide. And I said that when the body retains more carbon dioxide, the body becomes acidic in nature, or the blood becomes acidic. So asthma, then we have lung collapse. So we know atelectasis is same as lung collapse. So when the lungs collapses, or the alveolar sacs collapses, eventually the alveoli is that is where the gaseous exchange actually takes place. And so when you have the alveoli becoming collapsed, then that means that gaseous exchange cannot also take place. So the individual also retains what we call more of the carbon dioxide. Then we have brain trauma. And so we know that the respiratory centers are located within the brain, or the medulla oblongata. And so when you have a brain trauma, okay, it leads to a respiratory depression. And so when there's respiratory depression, the individual will retain more carbon dioxide. Then we have bronchitis. And so when you have the bronchi becoming dilated as a result of inflammation, and then that causes changes and the weakness in the walls of the bronchi, and that will also affect how carbon dioxide also gets eliminated from the lungs. Then anything that affects what we call gaseous exchange, think that it will cause the individual to experience respiratory acidosis. Then you have central nervous system depressant. And so that is why when you give someone a central nervous system depressant, let's say you give someone a benzodiazepine or you give someone diazepam, and then the respiratory system depresses. What happens is that the person is likely going to go into respiratory acidosis. Or when you give a medication that will have an effect on the central nervous system and can lead to respiratory depression, all those situations can cause an individual to experience respiratory acidosis. Then we have hypoventilation. And so when you are not breathing normally or when you are not breathing adequately, the breathing pattern is slow or the breathing pattern is slow. That is what hypoventilation is. So your breathing pattern is slowed. You retain more carbon dioxide. Then emphysema and then COPD, chronic obstructive pulmonary disease, the same scenario or the same way. Carbon dioxide is retained more. I mean, there is loss of elasticity of the alveolar sacs that restricts airflow in and out. And then as a result, the person retains more carbon dioxide. Then we have pneumonia, pulmonary edema, and then pulmonary emboli. So think about conditions that affect the lungs whenever you get a respiratory acidosis question. If it is a condition that affects the lungs, don't go and take metabolic. You take respiratory. Then come and decide, is it alkalosis or it is acidosis? And we are saying that if it is acidosis, what it means is that the carbon dioxide are more. Don't worry about the labs. We'll go into the labs. So in terms of the labs, when you see when you see respiratory acidosis, what you should look out for is that pH should be low. So you are looking at pH that is low, and you are looking at carbon dioxide that is high in terms of the labs. When we are talking about respiratory acidosis, we'll go into the labs proper and then we'll look at how to interpret them. But I'm just giving you an idea that when you get respiratory acidosis, what it means is that carbon dioxide is high and then pH is low. Okay, we'll go into the carbon dioxide figures and then that of the pH figures, and we'll get to understand that better. But this is what I want you to understand in terms of the labs, what happens to the two, pH and then carbon dioxide. Any question on the causes of respiratory acidosis before we go to what you see in someone with respiratory acidosis? Okay, let's look at our findings. Of course, you cannot do this without knowing what happens to the systems when someone is experiencing respiratory acidosis. And so when you take the cardiovascular system, what happens to it when someone is having respiratory acidosis is that there's going to be decreased blood pressure. And then the person will also have some form of abnormal heart rate rhythms, that is dysrhythmia. And so this is more related to, hyperkalemia from compensation. So because of, the excess the excess hydrogen ion in the system, potassium tries to move from the cells into the blood so that it will push the excess hydrogen ions into the cells, and that could lead to the dysrhythmia. When we do what we call electrolyte imbalances, you get to understand what happens to the heart proper when you have hyperkalemia. But you know that there's going to be that tall peak T wave and all those things. And so there's going to be abnormal heart rate rhythms when there is what we call respiratory acidosis as a result of hyperkalemia that comes in. Then you have warm flash skin. That is also as a result of peripheral dilation that also occurs during respiratory acidosis. Now, anyone experiencing respiratory problem, whether respiratory acidosis or respiratory alkalosis, what you have to watch out for is what happens to the the neurological system or neuro, what happens to the neuro. And so you see that there will be more confusion will come in, there will be lethargic dizziness, okay, and the loss of level of consciousness will all occur. And so neurologically, you will see that the person will become lethargic, confusion will come in, then there will be dizziness and then headache because of the accumulation of excess carbon dioxide in the system. Then neuromuscularly, you see that there's going to be muscle weakness, and then seizures can also occur when the individual is having respiratory acidosis. Now, in terms of the respiratory system, we know that the respiratory rate and depth will increase because the body is retaining more carbon dioxide as a form of a compensatory mechanism. The respiratory rates will have to increase in order to get rid of the carbon dioxide that has been retained in the body. However, if there is any form of respiratory problems and then the compensatory mechanism fails, the compensatory mechanism of bringing the carbon dioxide fails, then the person will go into what we call hypoventilation. And so normally we expect that if someone is experiencing respiratory acidosis as a form of a compensatory, just like when one is experiencing hypotension, tachycardia has to come in so that it will, as a form of a compensatory mechanism, so that it will pump more blood. The same thing if someone is retaining more carbon dioxide, the respiratory system will try to compensate by working extra harder to bring out the excess carbon dioxide. But when it fails, then there's going to be what we call hypoventilation at the end of the day. And so these are what we expect to see in someone who is experiencing respiratory acidosis in terms of assessment. Any question, any inputs, any clarification, any addition? Interventions for someone experiencing respiratory acidosis. If you just joined us, I said that I'm moderating the class today. Archimedes is out for today. He has had an emergency. He had to attend to it. And so I am moderating and I'm doing acid-base imbalances. I want to finish it today, so I'll try to finish everything today. Okay. Next week, he will come back and do GI with you. I realize some people just joined us. And so for those who just joined us, we are doing acid-base imbalances. We just started not long ago. We are doing respiratory acidosis now. Stay with us. If you have a question, you come in with your question. So interventions for someone experiencing respiratory acidosis. Of course, we are talking about things that are related to the respiratory system. And so you cannot intervene without monitoring the respiratory system. And so you have to monitor for signs of respiratory distress. Okay, whether the person is using respiratory accessory muscles, okay, to assist with respiration, you have to monitor for signs of respiratory distress. Then you have to give oxygen, okay, because the lungs has to bring out carbon dioxide and take in what we call, oxygen. But this time around, the person is retaining more carbon dioxide. So it means that the ability to bring out carbon dioxide is going to reduce. And so the level of oxygen in the blood will also reduce. And so that is why you need to administer oxygen. Then you place the client in a position that will facilitate what we call, breathing, and then assist with bringing the carbon dioxide out. So you assist with the client to assume a semi-fowler's position. You encourage and assist the client to turn, cough, and then also perform what we call deep breath. So deep breathing, coughing, and turning is very important. You have to reduce restlessness by improving ventilation rather than administering medications that will kind of, suppress the respiratory system. So when you notice that someone is experiencing, a restlessness, or the person becomes a little bit agitated and the person is having respiratory acidosis, Don't go and give medication that will suppress the respiratory centers or that will suppress the respiratory system. You will do more harm than good to the client. Okay. And so don't go give sedatives, opiates, okay, because these medications will further depress the respiratory system. Okay. So when you are reading your question and you realize that client is experiencing respiratory acidosis, and then in the medication, you have sedatives there or you have opiates, rule them out because when you give, they are going to suppress the respiratory system more, and the client will go further into the respiratory acidosis. You have to prepare to administer respiratory, treatment as prescribed. Suction the client's airway if necessary. If there is any form of blockage that is affecting, the compensatory mechanism of bringing the carbon dioxide out, you might have to suction to clear the airway. Then you have to prepare for endotracheal intubation, mechanical ventilation. If the client has severe acidosis and the carbon dioxide levels are above 50 millimeters of mercury, and the signs of acute respiratory distress are also present. So clients might end up in what we call having endotracheal intubation or being put on mechanical ventilation if the condition worsens. If the client has a condition that causes an obstruction of the airway or depresses the respiratory centers, you would have to monitor for respiratory acidosis. And so this is a take-home message that if you are managing any client and the client is having a condition that will suppress the respiratory system, you have to monitor the client for respiratory acidosis. And so we've gone through the conditions. We mentioned asthma, we mentioned COPD, we mentioned atelectasis, and then a number of conditions that you expect to see respiratory acidosis in them. Any question on respiratory acidosis before we go into respiratory alkalosis? Forgive me for my background, okay? And then I pray I am pleading with you to manage my background for me today so that next time I'll try to change the background to white so that everyone will be fine. Any questions on respiratory acidosis? Kindly feel free to ask questions, okay? Let me hear you. Are you guys with me? I'm talking a lot. Are you with me?
Yeah, we are here.
You are here. Okay.
Sir,
Okay.
so
You are-
is it when a client hyperventilates,
Mhm.
does it mean they have respiratory acidosis?
No. So we are now coming. So if the client is hyperventilation, the client will not during hyperventilation, the client will be bringing more carbon dioxide out. So under
Out.
normal circumstance, hyperventilation will lead to respiratory alkalosis, which we are coming to do.
Okay.
But when the person is experiencing respiratory acidosis, okay, when respiratory acidosis occur, the client will then start having hyperventilation in order to bring the
Compensate
carbon dioxide out.
Okay.
Are you getting the point I'm making?
Okay.
But if the client is not having respiratory acidosis and the person is hyperventilating, the client is likely going to end up in respiratory alkalosis.
Okay.
Is the scenario clear?
Yes, it's clear. So is it when the client is trying to hyperventilate to get rid of the excess carbon dioxide, is that when they give them a bag to breathe in and out from?
So we are now coming to talk about that. That is an intervention for respiratory alkalosis.
Okay. Thank you.
The paper bag, right?
Yeah.
Yes, so that is under respiratory alkalosis.
Okay, thank you.
So the paper bag comes in when a person is having respiratory alkalosis, or the person has gotten rid of excess carbon dioxide, and then the person needs to retain the carbon dioxide. So they give them the paper bag so that they breathe into the paper bag, and then it's like they breathe back again. And so they breathe back the carbon dioxide so that, they will have enough carbon dioxide in the lungs. So we are now coming to talk about that. That is under respiratory alkalosis. But in respiratory acidosis, we don't give an individual a paper bag because the person is already having excess carbon dioxide in the system. So why give paper bag for the person to breathe into it? I hope you get me.
Yes, sir. Yes, sir. Thank you.
Yes. Any further question? Any further inputs? Okay, so on respiratory alkalosis, it's just the opposite of what we just talked about. Now, what is happening here is that the person is bringing out more carbon dioxide. We said that carbon dioxide in itself is acidosis. So let me put this, let me get this. Okay, which color will be fine? Let me use white. Okay. So carbon dioxide, let me put the figure here for now. Carbon dioxide, the normal value for carbon dioxide is 35 to 45. Forget about the unit for now. Okay. Now, if you have carbon dioxide exceeding 45, let's say 50, we are looking at acidosis. Then, if you have carbon dioxide being less than 35, we are looking at alkalosis together with the pH. And so we know that pH, if the pH is also more than 7.35, 7.45, that is when we say the system is alkalotic. So in terms of the labs, okay, in respiratory alkalosis, we want to see pH more than 7.45. In respiratory alkalosis, pH should be more than 7.45. And then carbon dioxide should be less than 35. This is what we will see in terms of the labs. When we start the interpretation, you will get the understanding from there. But I just want you to put this one at the back of your mind. And so in respiratory alkalosis is where you have a deficit of carbonic acid, which is carbon dioxide, and then a decrease in what we call hydrogen ion concentration in the blood as a result of accumulation of what we call base, or yes, as a result of accumulation of base or from loss of acid without comparable loss of a base in the body. And so what this means is that respiratory alkalosis occur when an individual loses carbonic acid, which is carbon dioxide, and then in return, hydrogen ion levels in the blood drops, and so the body is not able to retain carbon dioxide and then hydrogen ion. Okay, that is what respiratory alkalosis means. The causes are what the NCLEX is going to ask you. So now think about conditions that causes an individual to bring out more carbon dioxide. Can we mention some of them? Let me engage you now. So now we understand respiratory alkalosis. Now let's now come up with conditions that we expect the individual to go into respiratory alkalosis. So what are the conditions that will make an individual to bring out more carbon dioxide? Anyone to try?
Anxiety.
Fever.
Yeah, anxiety.
Asthma.
Yes. Fever.
Pain.
Panic
Pain.
attack. When there is panic attack.
When there's panic attack. So when you do anxiety, right? When one is anxious and the person is panting, the person brings out more carbon dioxide. Okay, so someone talked about pain, someone talk about fever, someone talk about panic attack, or when an individual is anxious. Okay, the person is breathing fast. The person brings out more carbon dioxide. And so at the end of the day, it renders the system to be depleted of carbon dioxide, which is carbonic acid, and then in turn reduces the number of hydrogen ions in the system. So let's look into the conditions. I have a list of them. So someone mentioned of fever. Okay, so fever, it causes increased metabolism resulting in overstimulation of the respiratory system. And so fever will cause respiratory alkalosis. Then we have hyperventilation. And so the hyperventilation can occur from anxiety, panic attack, as we were mentioning. And so when one goes into panic attack or one is anxious, what happens? The person hyperventilates. The person breathe faster. And so they bring out more carbon dioxide. So hyperventilation, that's rapid respirations, causes the blowing off of carbon dioxide, leading to decrease in carbonic acid. We have hypoxia. Okay, and so when the body is depleted of what we call, adequate oxygen, and then you have excess carbon dioxide, the body will try to, take in more oxygen from the environment and bring out. So in return, you tend to have increased respiratory rates when one is having hypoxia. So hypoxia stimulates the respiratory centers in the brain, which causes an increase in the respiratory rate in order to increase oxygen levels, right? And this causes hyperventilation, which will lead to a decrease in oxygen level. And then overventilation. So when the client, yes, madam.
Kindly explain the hypoxia again, please.
And so I said that hypoxia is a state where you have a reduced oxygen level in the blood, right? And so because of the reduced oxygen levels in the blood, the body will try to compensate by bringing in more oxygen from the environment. And so in doing so, the respiratory centers will be stimulated. When it is stimulated, it in turn causes increased respiratory rate. And when respiratory rate also increases, hyperventilation will enter. So it's just like hyperventilation, but the cause of the hyperventilation is as a result of hypoxia. So the hypoxia will stimulate the hyperventilation to occur so that the body can take more oxygen from the environment in order to increase the oxygen level in the blood. Is that fine? So when that occurs,
Yes. Mm-hmm.
the body will bring out carbon dioxide, right? Because now you need more oxygen. And so you have to exchange the oxygen you are taking from the environment with the carbon dioxide.
Okay. So it's like a compensatory mechanism,
Yes.
kind of. Yeah. Okay.
So exchanging carbon dioxide with oxygen to increase the oxygen level in the blood.
Thank you.
Okay. And then when someone is also on mechanical ventilator and the person is overventilated, okay, and so overventilation by a mechanical ventilator, the administration of oxygen and then depletion of carbon dioxide can occur from mechanical ventilation, causing clients to be hyperventilated. And then we have pain. And so pain will also stimulate the respiratory centers in the brain, resulting in carbon dioxide deficit. If you have severe anxiety and hysteria, we were nurses. We've cared for people who are, who are exhibiting hysteria with us. Okay, and so they tend to want to breathe faster, and then that can lead to the excess exhaling of what we call carbon dioxide. And so respiratory acidosis look at things that causes an individual to bring out more carbon dioxide. And those are the things that causes what we call respiratory alkalosis. It will cause the total carbon dioxide in the system to be depleted. And at long last, leading to respiratory alkalosis. The person will experience low blood pressure, there's going to be tachycardia, and there's going to be dysrhythmia in terms of cardio system, what happens to the heart. With the neuro, same thing, dizziness, decreased level of consciousness, confusion, headache, lightheadedness, all okay. Then the GI system, they will tend to have some form of nausea, vomiting, diarrhea, and then epigastric pain. When you take respiratory acidosis, the GI system is not largely affected. That's why I didn't bring in the GI there. And so in respiratory acidosis, I mean, the GI is not mostly affected, but in respiratory alkalosis, the individual can experience some form of vomiting, nausea, diarrhea, and then some form of epigastric pain. They can also experience it. They can have tetany in terms of neuromuscular issues, numbness, tingling of the extremities, and then hyperreflexia, as well as seizure can also occur, all as a result of the, respiratory alkalosis, which can in turn cause issues of electrolyte imbalances. And then the electrolyte imbalances will cause the tetany, numbness, and tingling, largely calcium that regulates what we call the neuromuscular system. We have the respiratory system. So the respiratory rates and depth would decrease as a compensatory mechanism. So under normal circumstance, if someone is having hyperventilation, okay, and then the body wants to compensate, the body will compensate by depressing the respiratory system so that the hyperventilation that is going on will reduce, so the body can retain oxygen. So the body can retain, the carbon dioxide. Sorry for that. So originally the person will be having hyperventilation, but as a result of, but as a form of a compensatory mechanism, the body will now have to compensate by decreasing the respiratory centers, and the person will then experience decreased respiratory rate and depth. And then when the compensatory mechanism fails, what will happen is that the hyperventilation will keep on or will continue. So under normal circumstance, when someone is having hyperventilation, you expect the body to try to compensate. And then during the compensatory process, if it is successful, the hyperventilation will stop, and then the individual will rather go into hypoventilation. But if during the compensatory mechanism, that compensatory mechanism fails, that means that the hyperventilation will still continue, and then the individual will be breathing faster, and then as well, yes. When it comes to our interventions, you need to monitor for respiratory distress. You provide the client with emotional support and reassurance, especially if the person is experiencing, severe anxiety, or the cause is as a result of an emotional issues like, let's say, anxiety, panic attack. You would have to stay with the person. You would have to reassure the person, okay? And then you encourage appropriate breathing pattern. So this is where you have to engage the client in breathing techniques that will help the client to retain carbon dioxide. So the breathing techniques are assist the clients with breathing techniques and breathing aids if necessary, as prescribed. So the client would have to even hold his or her breath. You know that when you hold your breath, you are causing carbon dioxide to be retained in the system. So you hold your breath so that carbon dioxide, which is supposed to come out, will then be retained in the system. So using what we call rebreathing masks. And so we have a mask. When you take the various type of masks, rebreather mask is one of the masks that if someone is experiencing respiratory alkalosis, you give to the person so that the person breathe back the oxygen, okay, when they are hyperventilating. So using a rebreather mask, and then carbon dioxide breathe with rebreathing into the bag. So paper bag is used in respiratory alkalosis. Okay, so they give the person a bag. It's called a paper bag. The person uses it to cover the mouth or the nose. Okay, it's just like how the mask works. So that when the person breathes into the paper bag, the person will breathe back again, and then will now breathe the carbon dioxide back into the system. So that is how the paper bag works. So the paper bag is used in respiratory alkalosis. Let's take it from here. The NCLEX is going to ask, it's one of the NCLEX key points. The use of rebreather mask. We don't use we don't use paper bag in someone who is experiencing respiratory acidosis. It is used in someone who is hyperventilating and the person is experiencing respiratory alkalosis, so that the person can breathe back the carbon dioxide which the person is losing. You provide cautious care with ventilator clients so that they are not forced to take breath too deeply or rapidly. So for people who are on ventilator, when you are caring for them, you might have to be careful with their breathing pattern so that they don't retain excess of the carbon dioxide or they don't breathe out faster. Then you prepare to administer your calcium gluconate for tetany as prescribed. So I told you that the neuromuscular issues, the tetany, the numbness, and all those things that occur are largely as a result of electrolyte imbalances that will occur as a result of the respiratory acidosis, and then largely affecting what we call calcium. And so you have to give calcium gluconate to help target the tetany or treat what we call the tetany if it is prescribed. That is with respiratory alkalosis. Any question, any inputs, any clarification here? Then let's talk about metabolic acidosis. So now we are done with respiratory issues. So now when you hear about respiratory alkalosis, respiratory acidosis, you know where the problem is coming from. The problem is coming from what? The lungs or the respiratory system. Then let's talk about metabolic. The moment you hear about metabolic, take respiratory out. So any other cause of acid-base imbalance that is not as a result of a respiratory problem is a metabolic in nature. So it can be as a result of a GI problem that is leading to the imbalance. It is metabolic. If it is as a result of a urinary system, or if it is as a result of the kidneys, it is metabolic. As I hope that is fine. If it is not a respiratory problem, then it is a metabolic, whether it is a GI problem that is causing it or it is medication. So let's say someone has going to take salicylic acid, okay, or aspirin, and then it's causing the person to have excess what we call acid in the system. It is metabolic. If it is not a respiratory problem, think of metabolic. So same thing, we have metabolic acidosis, we have metabolic alkalosis. And then if it is metabolic, we are looking at what we call bicarbonate level. Okay. If it is metabolic, we are looking at bicarbonate level and pH. Same way we looked at carbon dioxide and pH when we're talking about a respiratory issue. When you are talking about metabolic issue, we are looking at bicarbonate levels and that of pH. That is the two we compare. And so we compare the two and then to determine what type of metabolic issue it is. So let's now deal with metabolic acidosis first. So a total concentration of the buffer base that is lower than normal with a relative increase in hydrogen ions in the system, resulting in loss of too much base or retention of too much acid. So these are, wordings, right? So what it's trying to say is that when someone is experiencing metabolic acidosis, what it means is that the individual will largely have a lower levels of base in the system, and then will rather have higher number of hydrogen ion, which is acid in the system. And then I said that we are looking at, if it is metabolic, we are looking at HCO3, that is bicarbonate, right? And then we are looking at pH. Initially, I told you that HCO3 levels are 22 to 26. I said forget about the unit, and then pH. Now, so we are talking about acid, right? And so we know that if something is acidic in nature, the thing in terms of pH will be low, right? It has to be less than 7.35, okay, for the system to be termed as being acidic. Then in terms of the bicarbonate and then pH have the same trend. It has to also be less than 22 for us to say the system is metabolic acidosis in nature. Don't worry, we'll look at the labs, but I'm just using this as an example for you to understand that in metabolic acidosis, we are looking at problems that could cause an individual to have excess hydrogen ions in the system. That is not as a result of a respiratory problem. So it could be as a result of a GI problem that is causing the person to have excess acid or excess hydrogen ion, or it could be as a result of the kidneys, because those are the two main organs that mostly leads to metabolic acidosis. That's why I'm mentioning kidneys and I'm mentioning the GI system. Okay, and so these are the scenarios that you expect someone to experience what you call metabolic acidosis. Now let's go into the causes. So when it comes to the causes of metabolic acidosis, first we'll talk about diabetes, okay, or DM or DKA. So that is why I believe when Archimedes did endocrine with you, he spoke about DKA, and then in DKA, you expect the individual to have metabolic acidosis because the person will be retaining more more hydrogen ions in the system. And so in DKA, there is insufficient supply of, or in DM, there is insufficient supply of insulin, and that causes what we call increased fat metabolism. And so the body would then depend on fats or breakdown of fats, and then the end product of fat metabolism is ketosis or ketones. And so the ketones, which is acid, will cause the individual to accumulate more hydrogen ions, which will then lead to the metabolic acidosis. So if you have come across a DM, and then we say that in DM, the person will experience metabolic acidosis, understand that the cause of the metabolic acidosis is because the person will break down what we call fats, stored fats, for glucogenesis, right? And then at the end of the day, after the breakdown of the fats, that the person will release, or the end product of fat metabolism is ketones. And then the ketones are acidic in nature, okay? And so the bicarbonate then end up being depleted. So the person will be depleted of bicarbonate levels, and hydrogen ion levels will rather go up, and the person will have what we call metabolic acidosis. So in DM or DKA, we expect the person to experience metabolic acidosis. When the person also takes in excess salicylic acid, that's the same as aspirin, eh? So excessive injection of acetylsalicylic acid, which is the same as aspirin, causes an increase in what we call hydrogen ion concentration in the blood, and that will lead to metabolic acidosis. High fat diet. So we understand that fat metabolism will lead to, ketones. And so the same thing, if someone likes taking too much of fatty foods, after digestion of fats, the end product, which is ketones, which is acidic in nature, will cause the individual to experience metabolic acidosis. When you have insufficient metabolism of carbohydrates, okay, insufficient metabolism of carbohydrates. And so when the oxygen supply is not sufficient for metabolism of carbohydrate, lactic acid or lactic acidosis will occur. And so if there is insufficient metabolism of carbohydrates, what ends up is that it leads to lactic acidosis. And when you have excess lactic acidosis in the system, the body becomes metabolic acidosis. Then we have malnutrition. And so malnutrition will also lead to buildup of ketones and then acid as a result of improper metabolism of nutrients, and then fat catabolism of fats. Because of the malnutrition that is ongoing, the body would depend largely on what we call store fats. And so the same thing, ketones will be released after the fat has been broken down. Then we have renal insufficiency. And so the kidneys are not functioning adequate to remove hydrogen ion or to remove what we call the waste products. And so the person ends up retaining acids. So ends product like protein metabolism, that is waste product of protein. When the body is not able to bring it out, they are retained. And we know that end product of protein metabolism is what? Is amino acid. So you have excess acid in the system, and that leads to metabolic acidosis. Then we have severe diarrhea. And so that is where the GI system comes in. We know that the GI system is predominantly what? Or the GI tract is predominantly acidic. And so if someone brings out, or the person someone is experiencing diarrhea, severe diarrhea, will lead to intestinal and pancreatic secretions, which are normally alkaline. Therefore, excessive loss of base leads to acidosis. And so when someone experiences severe diarrhea, the person tends to bring out more of the fluids within the intestinal tract, and that of pancreatic secretions tends to be lost. And these are mostly alkalotic in nature, or they are mostly alkaline in nature. And so it tends to lead the body, or it causes the body to be more acidic. And so if you have read before, they will say that if someone is bringing anything that is coming from, anything that is, if it is not vomiting, okay, if it is not vomiting and then it is coming from the rectum, it causes the body to be a metabolic alkalosis, because the person will be losing more base from, the feces or from the diarrhea, and then the system will become more of acidotic in nature. Then the opposite, if the person is then vomiting more, the vomiting will lead to decompression of what we call hydrochloric acid, or will bring up more of hydrochloric acid, and then the body will now become alkalotic in nature through the vomiting. But if it is through the rectum, it will lead to metabolic acidosis. That is what you need. So these are the conditions, these are the conditions that you expect to see an individual experiencing what we call metabolic acidosis. Any question, any inputs, any addition on the causes of metabolic acidosis? My questions are there, okay. I pray that I'm able to do this. I pray that I'm able to do this, and then when we get to the questions. So the findings in terms of neuro, the person is going to experience lethargy, the person is going to experience confusion, dizziness, headache, and then coma, right? Then cardiovascular, there's going to be decreased blood pressure. There's also going to be dysrhythmia as a result of the excess, potassium ion that has to come in order to control the acidosis. All right, so we have cold, clammy skin, which can also occur and will affect the cardiovascular system. GI system, they can have some form of nausea, vomiting, diarrhea as a form of a compensatory mechanism. Because we said that if the person is having vomiting, the person will have to bring out the excess acid in the system. Okay. And so the person will bring out more of the acid through the vomiting. And some could also have diarrhea and then abdominal pain. Then we have neuromuscular muscle weakness, seizures can also occur. Then respiratory rate. Now, when you do metabolic acidosis and then decay, we make mention of what? Kussmaul respiration. So in decay, we see Kussmaul respiration. How do we describe Kussmaul respiration? We say it is deep, rapid respiration, right? Deep, rapid respiration. And so that is a compensatory mechanism by the lungs in order to bring out carbon dioxide, which is also acidic. Because the system is already acidic, the lungs will try to compensate by bringing out excess carbon dioxide. So there's deep, rapid respiration, which we call Kussmaul respiration. And so if you did DK and my colleague mentioned Kussmaul respiration, the Kussmaul respiration is a compensatory mechanism that the lungs try to employ in order to reduce the excess carbon dioxide or the excess acid in the system. Then we have our interventions for someone who is experiencing metabolic acidosis. So intervention would largely target the cause. So if it is as a result of a renal problem, the client might need dialysis in order to bring out the waste. Okay. And so if it is DKA that is causing it, or it is DM that is causing it, you have to manage the DM. Okay. And so the interventions for metabolic acidosis is largely depends on the cause. And so you target the cause and then you treat the cause. And so interventions, you have to, monitor the respiratory system for any form of respiratory distress. Then you monitor intake and output, and then assist with fluid and electrolytes, replacement as prescribed. Like someone who is experiencing, DKA, you have to monitor potassium levels. You have to monitor fluid levels. You might have to give your IV fluids, your normal saline, right? Then you prepare to administer solutions intravenously as prescribed to increase the buffer base. Okay, so mostly you have to give your IV fluids to also neutralize the system. When it is DK or it is DM that is causing it, we know insulin is what the person is lacking. And so you have to give the person insulin to hasten the movement of glucose into the cells. And then in return, thereby decreasing what we call the concurrent ketosis that is happening. Because we said that the ketosis is because the cells are not getting adequate glucose from metabolism, okay? Or the cells are not able to use what we call the glucose that is in the blood. as a result of lack of insulin. And so the cells then depends on what we call fat metabolism. And so if you give the insulin would then push the excess glucose that is in the blood into the cells for the cells to use them, thereby reducing the fat metabolism. I hope that's fine. Then when glucose is properly metabolized, the body will stop converting fat to glucose. That's what I just said. You monitor for circulatory collapse caused by polyuria, which may result from hyperglycemic state, and then osmotic diuresis may lead to extracellular fluid deficit. So you might have to monitor for any form of respiratory collapse, because we know that in DKA, one of the main issues was polyuria, excess urination. And so the person become depleted of fluids. Okay, dehydration can occur, which can lead to respiratory collapse. Then if DKA is present, you need to establish your IV line, prepare to administer your IV fluids for resuscitation. You monitor your electrolytes, your glucose level, and then your urine output. You need to monitor it. If the problem is as a result of kidney, okay, if it is a kidney problem, that is why I was saying that it means that the kidneys are not working adequately to get rid of what we call, the waste products. So you have to perform your dialysis, and then the waste products will come out. Then the client will need to take in low protein diet, high calories to decrease the amount of protein waste, because we said that after metabolism of protein, the end product is what? Amino acid. And so it largely get eliminated through the kidneys. And so if the kidneys are affected, it means that there will be buildup of waste product of protein. And so you have the individual having to limit the intake of what we call protein in order to decrease the waste product of protein that gets accumulated within the system, leading to the acidosis. That brings us to an end to metabolic acidosis. Any question on metabolic acidosis before we go to metabolic acidosis? And then we'll do that briefly, then we'll go into our calculations. Any question, any inputs, any additions? Okay, let's do metabolic alkalosis, and then we'll just finish very soon. So in metabolic alkalosis, the opposite for what I spoke about in terms of the labs. So in metabolic alkalosis, you have the individual losing more acid or losing more hydrogen ions, and rather retaining more base or retaining more bicarbonates. Okay, and so there's a deficit of carbonic acid and a decrease in hydrogen ion concentration, resulting from accumulation of base or from a loss of acid without a comparable loss of base in the body. So the body does not lose base, and so the body tends to accumulate base, or it is either the person is losing more acid rather. And so it could be that the base system is normal, but the person is losing more acid. And so because you are losing more acid, the base, which was normal, tends to become more than the acid. And you then ends up having metabolic acidosis. So metabolic alkalosis, okay, metabolic alkalosis. So you have more base, or you are losing more acid. And so the normal base that was there tends to become abnormal at the end of the day. And so you tend to have excess, what we call base in the system, if you are having metabolic alkalosis. And remember, it is metabolic, so the problem is not coming from the lungs or the respiratory system. Causes of metabolic alkalosis result from a dysfunction of metabolism that causes an increased amount of available base solution in the blood, or a decrease in the available of acid in the blood. So it is either the number of acids or the amount of acid in the blood is decreased, or the number of base or the amount of base in the blood has increased. That is what will cause one to experience metabolic alkalosis. And so the causes, what are some of the issues that could lead an individual into having metabolic alkalosis? We have diuretic. And so people who uses diuretics a lot. And so the diuretics will cause the kidneys to produce more urine. And so as the person urinates more, the person brings out more acid. And so at the end of the day, the person will tend to lose more hydrogen ion, and then excess base will be accumulated. So the loss of hydrogen ions and chlorine or chloride from diuresis causes a compensatory increase in the amount of bicarb in the blood. Then another cause is excessive vomiting or GI sanction. And so in the questions, you see it a lot. A client undergoing suctioning, or you are performing suctioning on a client, which of the electrolyte imbalances you expect to see? And you see metabolic acidosis, you see metabolic alkalosis, then they will bring the respiratories as well. So from here, if after today's class you meet any question regarding suctioning and they are asking about that's GI suctioning, and they are asking about which of the electrolyte imbalance, which of the acid-base imbalance you expect to see, understand that you expect to see metabolic alkalosis in GI suction. Why metabolic alkalosis? Metabolic alkalosis because you know that the stomach, okay, is predominantly what? Acidic. That is hydrochloric acid. You have more hydrochloric acid in your stomach. And so when you suction the stomach and you bring out the acid, the hydrochloric acid, what do you think will happen? The body will lose acid, and then the amount of carbon dioxide, the amount of bicarbonate, which is the base, will rather go up. Even if it is normal, it will exceed the acid level. And so the body will end up in what we call metabolic alkalosis. So excessive vomiting, same thing. The person will bring out more of the contents in the GI tract or in the stomach. And so when you vomit, you are vomiting acid out. And so the body becomes depleted of what you call hydrogen ions and then carbonic acid or hydrochloric acid. So you tend to have metabolic alkalosis. Then we have hyperaldosteronism. And so this is increased renal tubular reabsorption of sodium with the resultant loss of hydrogen ions. And so in hyperaldosteronism, the kidneys absorb more of sodium and then rather get rid of hydrogen ions, and the person who tends to have metabolic alkalosis. Then when the person injects excess bicarbonate, it could be through medication. Let's say you are giving medication that contains excess bicarb. You have to monitor for metabolic alkalosis. So injection or infusion of excess sodium bicarbonate causes an increase in the amount of base in the blood. So when you are giving sodium bicarbonate to a client, monitor for what you call metabolic alkalosis. And then blood transfusion. So this one too, they like asking, when you are giving blood, which of the electrolyte imbalances you have to monitor? When they are preparing the blood, they use, what we call citrate. Okay, citrate is an anticoagulant that the lab people use to prepare the blood for the transfusion. And so it is an anticoagulant that is added to the blood in order to prevent the blood from clotting. Other than that, the moment they take they bleed someone, the blood would have clotted. And so they add citrate to it as a form of anticoagulant in order to store the blood for a longer duration. But citrates, when metabolized, okay, becomes I mean, when citrate is metabolized, or citrate can be metabolized in the system into bicarbonate. And we know that bicarbonate is a base. So when you are giving blood to a person, or when you are giving too much blood, excessive blood to a client, and then the asking of which of the electrolyte imbalances you expect to monitor, understand that you have to monitor the client for metabolic alkalosis because of the citrates in the blood, which will be metabolized into bicarbonate, and then that will lead to excessive base in the system. Is that clear? Are we fine with that? Then on assessment, we expect to see the same thing. I've said that in acid-base imbalance, when you take the neuro, you realize that lethargy, irritability, confusion, headache runs through all of them. Okay, because when you have an imbalance in any of the two, whether acid or base, the effect on what we call the neuro, the brain, is largely the same. So it could lead to lethargy, irritability, confusion, and headache. With the cardio system, the clients will have low blood pressure. There will be tachycardia, dysrhythmia as well. GI tract issues, nausea, vomiting can also occur. Then neuromuscular clients will have tetany, tremors, tingling of the extremities, muscle cramps, and then hypertonic muscle, that is hyperreflexia, and then as well as seizure. The respiratory system, client is going to have rapid respiratory rate and depth will decrease as a compensatory action to retain carbon dioxide because the system is now alkalotic. You need acid. And so the lungs try to compensate by retaining carbon dioxide. So you realize that respiratory rates decrease in order to retain carbon dioxide so that it will kind of neutralizes the alkalotic states. But if the compensatory mechanism fails, hyperventilation will occur. Okay. Just like we talk about. Interventions for metabolic alkalosis. You need to monitor for respiratory distress. You have to, prepare to administer medications, IV fluids as prescribed to promote the kidney excretion of the excess biocarb. And then you might have to prepare to replace what we call potassium as also prescribed. So people with, we know that in metabolic acidosis, right? In metabolic acidosis, like someone experiencing what we call decay, potassium levels are high. But in metabolic alkalosis, potassium levels drop. And so you have to replace what we call potassium in someone experiencing metabolic alkalosis. Any question, any inputs before we go into our arterial blood gas analysis? Hey, can I finish this? All right, let me try if I can finish. Okay, I'll try to see. And is there any question? Yes, hello.
Yeah, please. I didn't join early though, but please, in metabolic acidosis, you said I prescribe IV fluid. Please, is it the prescribed IV fluid? Is it Ringers or which of the
Normal,
IV fluid?
mostly normal. So largely it will be normal saline. Okay, to help clear what we call the excess waste, and then also enhance the kidney's ability to excrete the excess bicarbonate.
Okay, thank you.
Yes, so you didn't join early, right? So you have the recording. Please, what causes potassium to drop in metabolic acidosis? Now, I didn't say in metabolic acidosis, potassium will drop. So when you decay, okay, in decay, what happens to potassium levels are high, right? So the potassium levels are high. The potassium also, as a way to compensate, okay, the potassium comes in as a way to also reduces the acidic nature by pushing more of the hydrogen ion into what we call the cells. So in metabolic acidosis, potassium levels will not drop. It is rather in what we call metabolic alkalosis. That is where potassium levels will drop. Just the opposite of what happens in decay. And so the body, there's depletion of what we call potassium levels in someone who is experiencing metabolic alkalosis. And so you will give the potassium so that you replace potassium, and potassium will also help, because we said that when it comes to the regulatory system of the acid base, you need potassium. Potassium plays very key role. Okay. And another thing that also causes the depletion of the potassium is that because of the excess bicarbonate or the excess alkalosis in the system or base in the system, they also pushes the potassium in the blood into the cells. And so at the end of the day, you have hypokalemia in someone with metabolic alkalosis. So I didn't see in metabolic acidosis. That is Benis. Madam Ben, is that what you? In metabolic acidosis, potassium level will rather be high. In metabolic alkalosis, potassium levels are reduced because the base will push the potassiums into the cells. And so you have the amount of potassium circulating in the blood reducing in metabolic alkalosis. And so that is why in the interventions, I said that you have to replace potassium in metabolic alkalosis. Is it NM? Yes. If I had your hand is up, right? You can come.
Yes. Okay, please. With the metabolic alkalosis, you said a massive transfusion of whole blood. So, if maybe you get a question and it's just transfusion, is it also still metabolic alkalosis?
Oh,
Or
yes.
unless
So if the question is a patient receiving blood, okay, whether they use massive or not, and the question asks you, a client receiving blood, which of the electrolyte imbalances you monitor? It is still metabolic alkalosis.
Okay, thank you.
But just that the metabolic acidosis is largely seen in people who takes too much, like taking excess blood. Are you getting the point I'm trying to make?
Yes, please. Okay. Thank you.
Any other question? Inputs? Kindly ask
Can you take
questions.
the potassium hypo and hyperkalemia with the metabolic thing, please?
Okay, so I said that in someone experiencing metabolic acidosis, you expect potassium levels to be high. Okay, so what happens is that the system knows that there is too much acid in the blood. And so you have the potassium, which are supposed to be in the blood, which are supposed to be in the cells, moving into the blood, trying to compensate by moving the hydrogen's ion, which causes the acid, also back into what we call the cells. So you see metabolic acidosis, you see hyperkalemia, that is high potassium levels in people with metabolic acidosis. And so I gave you an example that in decay, we say what? Hyperkalemia in decay. And decay, you expect to see metabolic acidosis, right? And so the excess potassium, which is in the blood, they are there to push more of the hydrogen ions into what we call the cells. But when you take metabolic alkalosis, what you see is hypokalemia, that is reduced potassium levels. And what happens is that this time around, the bicarbonate level are more. So the bicarbonate rather pushes potassium into the cells and then renders the blood a depletion of potassium. So in your management, you would have to replace the lost potassium. And so you give potassium in metabolic alkalosis. Exactly.
Yes, sir. Thank you.
All right. Any other question? But I want us to do the main job. And I want us to do the main job, which is how to do the interpretation, right? Or how to interpret. And so I might borrow some of your time. And so when you are, let's now come to arterial blood gas analysis or arterial blood gas. And so before you do your ABGs, you know that you need to take a sample to the lab. And so the sample has to be taken to the lab, and the lab will do, their investigation and give you the results. And so you cannot just take the sample. You have to understand how the sample is taken. Okay. That place, there are questions. Okay. What you need to do. If the client is on oxygen, do you need to document it? On which part of the hands or which part of the arteries do you take the sample from? So you need to understand all those things. So when it comes to arterial blood gas, in terms of sample collection or specimen collection, first, before you take your sample, you need to monitor, you have to obtain the vitals. You need to know the level of oxygen and then the other components. Okay. Then determine whether the client has an arterial line in place. Allows for arterial blood sample without further puncturing in the client. So if the client has an arterial line in place, you can use that arterial line that is already in place for your sample. If the client is not having, then you might have to pass an arterial line for what we call, or you might have to do your puncturing for your sample. Then one test that is done before the sample is taken is the Allen test. And so I believe we have come across the Allen test too. So we'll go through the Allen test as well, and then we know what goes into the Allen test. So the Allen test is performed to determine the presence of collateral circulation. Note that in most facilities, an arterial blood gas, arterial blood gas sample is mostly drawn by the respiratory therapist. But you need to know how the Allen test is performed. So the Allen test is performed to determine that if the arterial or if the vessel is injured, okay, or let's say, so you use the ulnar artery and that of the let me get that correct for you. So we use the ulnar artery and then the radial artery. That's fine. So you want to test to see that if, let's say, the radial artery, because that is where the sample is taken, if the radial artery is injured, let's say during the procedure, can the ulnar artery supply the hands or the extremity with adequate circulation or the adequate blood? And so if you do it and then the result is positive, so we'll do and then we'll go through and know what is positive and negative. When you do your Allen test and the result is positive, it means that in a case where you take the sample and then the artery get damaged, okay, that is the radial artery get damaged, you can depend on the ulnar artery, which will then supply the hands or will supply the extremity with blood. But if you do and it is negative, what it means is that should in case after your procedure, the radial artery is damaged, the ulnar artery will not be able to supply adequate blood to what you call the hands. And so you might have to perform the procedure on the opposite hand, then to also determine if you can pick the sample there. And so that is the essence of performing what we call the Allen test. Then you need to assess factors that may affect the accuracy of what you call the results, such as changes in oxygen setting. If the client is, suctioning within the past 20 minutes, and then the client's activity. So before you take the sample for your arterial blood gas analysis, you would have to, assess the client to see, has the client engaged in any activity that could cause a depletion in oxygen levels, like maybe activities like maybe walking or perform any vigorous activity that can affect the saturation or oxygen level, or client has, undergone suctioning, which can affect oxygen level within the blood. If any of these things exist, the sample might not be taken, because if you take the sample, it might affect what we call the results that you are going to get. It can cause the concentration of oxygen in the blood to reduce. Then you would have to provide emotional support to the clients. Then you assist with specimen collection, the drawing of what we call the specimen. Like I said, it's mostly done by, a respiratory therapist, okay, but you have to assist in the procedure. You need to understand that the sample is mostly taken with a syringe that has heparin in it to prevent the blood from clotting. So prepare a heparinized syringe, if not already pre-packaged. After obtaining a specimen, prevent any air from entering the syringe, because air can cause a change in what we call the results, okay? You don't want any air from the outside to get into what you call the syringe. That could affect the results. Then apply pressure immediately to the puncture site following what we call the blood drawn, or after the blood sample has been taken. You need to apply pressure immediately at the puncture site, and so you maintain the pressure for about 5 to 10 minutes, okay, if the client is taking anticoagulants, okay, or for 5 minutes or for 10 minutes. So for clients who are taking anticoagulants, you might have to apply the pressure for at least 10 minutes, but for normal individual, 5 minutes will be enough. Then you assess the radial pulses after removing the pressure. Like I said, the sample is mostly taken from the radial artery. So after taking the sample and after releasing the pressure, you assess the radial pulses to see if everything has retained. Then you have to label the specimen and transport it on ice to the lab. Remember how the sample is transported. It is examinable, area, how the sample is transported. So you need to make sure that the sample is well labeled. Then you transport it on ice to the lab to prevent any form of, alteration that can occur when you just send it. So you need to maintain it at a certain temperature. Okay, that's why it needs to be kept on an ice to prevent any form of alteration. Then if the client was on oxygen when the sample was being taken, you have to indicate that on the laboratory form. That is why you need to take the temperature and then indicate the temperature, because they can all affect the result. Okay, they can all affect what we call the result. So on the laboratory form, record the client's temperature and then the type of supplemental oxygen the client was receiving. So these are examinable things. That's why I've taken my time to do it with you. You have to record if the client was on oxygen, you indicate the amount of oxygen the client was receiving. You need to indicate whether, the client's temperature, you need to indicate that. Then you need to transport the sample to the lab on an ice, okay? That is with sample collection with arterial blood gases when you are going to do your analysis, how you take the sample. It is very important. Then let's look at, yes, any question on sample collection on arterial blood gases? Any question? Any question? Yes, D. Yes, D, you can unmute.
Sir,
Yes, hello, Madam D.
please, when is the sample supposed to be taken? Is it at any time or it has a specific time?
Immediately you take the sample, you have to transport it. So if you cannot transport it, then you have to, if you cannot transport it, you have to make sure that it is kept in a freezer. Oh, sorry, a refrigerator. Sorry, not freezer, a refrigerator. But the sample should be collected. The moment the sample is collected, it has to be sent immediately. And then you have to put it on ice when you are sending it. But in a case where, for one reason or the other, you cannot send a sample, you have to make sure that the sample is kept in the refrigerator.
Okay, so please, does it have a specific time that it should be taken or
Mean the time the sample should be taken.
like maybe
Early in the morning.
oh, okay.
Or is that, no, I'm asking, do you mean like a specific time, like early in the morning, or let's say afternoon or evening? Is that what you are trying to ask?
Please.
That's what we are trying to ask, right? So the sample can be
Yes,
taken
please.
anytime. It doesn't have like a specific time of the day that this is the specific, but before you take it, you have to consider the client's situation. Just like I was saying, if the client has engaged in any activity that you think will affect the oxygen level, you don't take the sample. You have to probably wait. Okay. And so if, let's say, you have suctioned the client, you know that when you suction the client, it also causes a depletion in the oxygen level. That's why when you are suctioning, we say we don't suction past 15 seconds, right? When you are suctioning, you don't suction past 15 seconds. Because if you suction, the more you suction, the more, the oxygen level also reduces. And so ideally the sample can be taken anytime during the day, but you have to consider the client's condition before you take the sample.
Thank you.
Yes. Any question?
Yeah, sorry. This is I was trying to say that I think my connection was something else. When you
Okay.
were talking about the collection of the sampling for the ABG, I think it's a little suggestion. I mean, you can correct me too.
Okay.
You spoke about the temperature and then the oxygen level and all that. I think when the patient is on ventilator, I stand to be corrected. I think you need to add up the saturation levels and then the levels that the vent is on. Either if it is BiPAP, CPAP, and all that. That's the little I know. I don't know if that is also correct. So
I stated it here that
okay.
if the client is on oxygen, okay, if the client is on oxygen, for the ventilator, I didn't mention that. But if the client is on any, machine or anything that affects the level of oxygen or the client's saturation level, you have to indicate it on the form.
Okay. Thank you.
So, yeah, so I stated the oxygen here, that if client is on oxygen, you have to indicate on the form my client was on oxygen. The amount of oxygen the client is even receiving has to be indicated. And then the temperature needs to be indicated on the form. I stated all that. So like you said, probably maybe you were offline.
No, I was talking about the ventilator, like the
Yes.
vent. I don't know if you mentioned it. Okay, then.
So
Okay, thank you.
that's why I said, as for the vent, I didn't mention that. So similarly, if the client is on vent, you would have to indicate that client is on a ventilator.
Okay, thank you.
Yes. Thank you. Any other input here? Okay, so let's briefly go through the Allen test. I said today I'll take some of your time. I don't want to come back again and then, because next week I'm not coming back to do this. So just give me maybe 20 minutes of your time so that I can finish this. When it comes to Allen test, so Allen test is performed, okay, Allen's test to determine collateral circulation. And so you are performing it to see if you take the sample from the radial artery and then the something happens in the radial artery, can the ulnar artery perform? Would it be adequate to be able to, supply the hands or the extremity with adequate blood supply? That is all the purpose of this. And so before you do the procedure, you need to explain the procedure to the client, or before you perform. It's non-invasive. Okay, it's just pressures you are going to just apply. Ask the client to clench the hands and then releases, and then look at circulation at the hands. So you need to explain procedure, the purpose of why you are performing the Allen test to the client. Then pressure is applied. When I'm done, I'll show you the picture. Okay, I'll Google it for you to see. Pressure is applied over the ulnar and then the radial artery simultaneously. And so the ulnar artery and then the radial artery, the pressure is applied over there simultaneously. The client is asked to open and close the hands repeatedly whilst you have occluded what we call the arteries, whilst you have occluded the ulnar and the radial arteries. Then pressure is released from the ulnar artery whilst compressing what you call the radial artery. So what you do is that you release pressure on the ulnar artery, then you maintain the pressure on the radial artery. Pressure on the ulnar artery is released. Pressure on the radial artery is maintained. What you see is that the color of the extremity that is distal to the point is assessed. If flow through the ulnar artery is good, you see that flashing will be seen immediately, mostly within 5 seconds. You have to see, in samples they'll say 5 to 10 seconds, you have to see that flashing. The moment you remove your hands from the moment you release the pressure from the ulnar artery, you must see a flashing immediately within 5 to 10 seconds in what we call the arms or the hands. So if the flow through the ulnar artery is good, flashing will be seen immediately. What it means is that the test is now considered positive, and the radial artery can then be used for the puncturing, so that in case you puncture the radial artery, the ulnar artery can stay and perform the function without any problem. However, if you release what we call the pressure from the ulnar artery and then flashing is not seen, that means that the test is negative, and then you need to repeat. The test is repeated on the other arm. If both arms give a negative result, another artery is selected for the puncturing. So when it is negative, what it means is that blood flow through the ulnar artery is not quite adequate to be able to supply the arm. In case you puncture what we call the radial artery and then it is damaged, the ulnar artery might not be able to stay in and perform the function that is supposed to perform. The findings are then documented. So let me see if I can show you a picture of what I'm trying to explain. And so when you are learning for the NCLEX, you need to know about Allen test. and then when Allen test is performed. Okay. So let me see if I can get an image. Yes. So this is what I was trying to say. Okay. So you occlude. You can see how. So you have the anal artery here, you have the radial artery here, right? And so you occlude the two simultaneously, just like you are seeing here. You ask the client to open the arms and then close it, okay, maybe several times. Then you release the pressure on the anal artery whilst you maintain pressure on the radial artery. If the anal artery is functioning adequately and supplying adequate blood, the moment you release the pressure from what you call the anal artery, that you must see flashing of the arms. Okay, you must see flashing occurring in the arms here. If flashing doesn't occur immediately within 5 to 10 seconds, it means the test is negative. You cannot use that radial artery for the sample. You might have to repeat the test on the other arm. If the same thing happens on the other arm, then the radiotherapist or the one taking the sample would have to choose a different artery for what we call the test. And that is what Allen test does. Any question on Allen test, any input on Allen test, and how Allen tests are performed? Any question on Allen tests? Means we are fine on Allen tests, right? So please, when you are reading and you come across why we do Allen tests, understand that Allen test is done to assess for collateral circulation before what we call arterial blood gas sample are taken. Then this is where I want to take your time for us to simply go through arterial blood gas analysis. I've already spoken up a lot about the normal values of what we expect to see. So pH, the normal pH is what? 7.35 to 7.45. Carbon dioxide is 35 to 45, right? This is the normal range. Bicarbonate is 22 to 26. Then oxygen, partial pressure of oxygen is 88 to 100. Remember, we are not talking about SpO2. SpO2, in terms of the normal value, is different from partial pressure of oxygen. They are two different things. And so for normal partial pressure, for oxygen, the normal is 100 to 80 to 100. In fact, in arterial blood gas analysis, we don't consider it. Okay, it's just a redundant, should I say, indicator. We don't use oxygen when we are determining what is happening in the system. These are the three things: pH, biocarb, and then carbon dioxide. These are the main things that I want us to take note of when we are doing our interpretation. What I have here, I don't want us to go through it. We are going to use examples to explain everything. So when it comes to ABG interpretation, we are going to use what we call the tic-tac-toe method. Okay. And so the tic-tac-toe method, let me start my tic-tac-toe method. Let me draw it here. It is in what I have just said. So we'll do this here, these three things. We do acid here, we do normal here, and then we do base here. Base, acid is acidosis, base is alkalotic or alkaline, right? And so this is what we are going to do to interpret ABGs. Now, in ABGs, we have three scenarios. We have either the system is respiratory, or either we have uncompensated scenario, or we have partially compensated. and then fully compensated. These are the three scenarios I want everyone to take note of. Partially compensated, fully compensated, and then uncompensated scenarios. Now, we will start with the uncompensated. And so uncompensated means that you have, when you have, let's say, respiratory acidosis occurring, the metabolic system will not be doing anything to try to compensate for what is happening. And so you see the metabolic system remaining within the normal range. And then the issue happening with only the respiratory system and that of the pH. That is when we say it is uncompensated. We'll use the figures to explain. Then when we say partially compensation, in partial compensation, let me use the same example. Let's say a client is having respiratory, let's say acidosis. Carbon dioxide level is high, pH is down. Then when you check the metabolic level, you realize that the metabolic level will be out of the normal range. The metabolic level will now go up. That is, bicarbonate will go up. And so bicarbonate will go up, trying to kind of compensate, okay, trying to bring the pH back to normal. But it will not be enough to bring the pH back to normal. So you still see the pH being abnormal. And then what is causing the problem, which is the respiratory, is also not abnormal. And then the other one will also be abnormal. All that I'm talking about, we use example. Then when we talk about fully compensation, in full compensation, pH will be normal. But when we say pH is normal, in fact, in normal pH, we know that the blood pH, I said, is what? Between, let me use this line. Let me put 7.40 here. And then let me put 7.45 here. Let me put 7.35 here. I hope you guys are monitoring. Now, when we say pH is normal, normal pH means that pH is supposed to be between 7.35 to 7.45. That is the normal pH. But we have something we call absolute pH. I take it again. We have something we call absolute pH. And absolute pH is when you have the pH being 7.40 here. When you have pH being 7.40, it means that the pH is absolutely normal. However, if you have pH between 7.35 to 7.40, it is still normal, but it is going more towards the acidic. We know that when the pH is going this way, it is what? Acid. So between 7.35 to 7.40, pH is normal, but it is still towards the acidic way. And similarly, when you have pH between 7.40 to 7.45, it is normal, but it is leaning towards what? The alkalotic way, or it is going towards base, even though it is still normal. And so when you get a question, and the question is about fully compensation, what you need to look out for is that, is the pH within the normal range? If it is within the normal range, which side of the normal is it towards? Is it towards the acid, or is it towards the base? And that will tell you that you are having either respiratory acidosis, which is fully compensated, or metabolic acidosis, which is fully compensated, or the other way. I hope you guys are following what I'm doing with you. So I'm saying that pH, which is between 7.35 to 7.45, can either be acid or base, depending on which side the value is going towards. But an absolute pH is 7.40. And we consider that when we are talking about full compensation. So now, let's go through an example. I have a lot, and so what we need to understand is that when you take carbon dioxide, understand that carbon dioxide, I said carbon dioxide is one acid. Under normal circumstance, where you have excess carbon dioxide, it is acid. So if carbon dioxide is greater than 45, it is considered as acid. So you see the system behaving acidic. And then when carbon dioxide is less than 35, you see the system behaving alkalotic. Base is, sorry, bicarbonate. Okay, bicarbonate in itself is considered as a base. And so if you have more bicarbonate, the system is likely to be alkalotic. And then when you have less of bicarbonate, the system is more likely to be acidic. Now, let me state again that if you have a problem and the problem is as a result of carbon dioxide, we say the problem is respiratory. Okay. And then if you have a problem and the problem is as a result of bicarbonate, we say the system is what we call metabolic. I've talked a lot. Let's use the tic-tac-toe method to take an example. So for now, we are looking at uncompensated. Okay, uncompensated. The system is not doing anything to try to regulate what is happening. So let me come pick my example here, and then we'll use that. And so let me look at an example. So let's use this example. I have an example here. Okay, let's use this example. The first example is what we are going to use. Let me write it here. We say pH is, so pick your books, okay? pH is 7.22. CO2 is 49. And then biocarb or HCO3 is 24. Pick your pens. Let's go back here. Okay, so I said that we are going to use the tic-tac-toe method, right? And so the tic-tac-toe method, what you do is that you draw this. You draw your 3 lines, right? You draw your 3 lines here. We are drawing our 3 lines here. And then you put acid here. You put normal here in the middle. Then you put base here. Okay. Now, the pH. What is the pH? The pH is 7.22. This one I'm doing with you. The pH is 7.22. Is it acidic or it is alkalotic? 7.22. Is it an acid or base?
Acid.
Acid.
It is acid. So pH comes here. Okay. Now let's look at our carbon dioxide. Carbon dioxide is 49. It is more than the normal, true or false?
True.
Carbon dioxide is 49, and I'm asking it is more than 49. So it's more than the normal, true or false?
True.
True. And then we said that carbon dioxide itself is acidic, true or false?
True.
True. So if it is carbon dioxide in itself is acidic, and then it is more than the normal, would the carbon dioxide fall under acid or base?
Acid.
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 Carb is 24. The normal is 22 to 26. Is it normal or abnormal?
It's
Normal.
normal.
It's normal or abnormal?
It's normal.
Normal.
Have 2 on one side, it means that you know how to name it. So now we know that your pH and then your carbon dioxide all fall under acid. So you know now the system is acidic. And now you know that because it is carbon dioxide, the problem is what? Is it respiratory or metabolic?
Respiratory.
Respiratory. So now we can name it as respiratory
Acidosis.
Now, this is the basic, interpretation that based on what I give you, it is respiratory acidosis. But let's come to the bicarbonate. We realize that the bicarbonate is normal. So it is not doing anything to compensate for the system or to compensate for what is happening. So we then add that it is what? Uncompensated. So if you want to fully name this, we say that respiratory acidosis uncompensated. Uncompensated means that the bicarbonate, which is a base, is within the normal range. It is not doing anything to try to bring, or neutralize the acidic nature. And so the system is remaining as it is. The base system is remaining as it is. It is not doing anything. So it is unbothered. It is uncompensated. So we say respiratory acidosis uncompensated. Do we get it?
Yes, sir.
Yes, sir.
Should we take another example?
Yes, sir.
Yes, please.
Okay. So let me go back to my question. Sorry, as I said, I want to finish. I don't want to come back to it again because that means I'll have to drop maybe about 2-3 weeks later before I come back. And so that's why I'm taking your time. So don't leave, okay? Don't leave me. Stay with me, okay? So let's take another example. Okay, we can even stay here so that we use the screen here since we have the questions here. So I want an uncompensated figure, one uncompensated, one uncompensated, one uncompensated. Okay, so I have another one. So we are using this coming. We are using this one here, this question. The one I have under, no, not this one rather, this one. So we have pH, we have pH of 7.39, carbon dioxide of 50. Sorry, this one is 28 rather. pH is 7.28 rather. 7.28. This question is what I'm using. This one. Carbon dioxide 50. Bicarbonates. So CHO3 is 24. Okay, it's 24. So now let's use our tic-tac-toe here. We have acid here. We have base. Sorry, we have normal in the middle. We have normal here, and then we have a base here. Now, let's look at our pH. Our pH is 7.28. 7.28. Is it acid or base?
Acid.
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 Good.
So pH comes here. Then we look at 50. Is it acid or base? Carbon dioxide is 50. Is it acid or base?
Acid.
Acid.
Are we all sure it's acid?
Yes, sir.
So we say it is acid. Then we come to the bicarbonate. Bicarbonate is 24. Is it normal or it's the other way around? What do we think? Bicarbonate. Is it normal? Is it base? Is it acid here?
Normal.
24. Bicarbonate of 24. So we put it under normal, right? So CO3 is normal. So now let's name it. How then do we name this one too? How then do we name this?
Uncompensated respiratory acidosis.
So uncompensated, right?
Yes.
Uncompensated.
Yes.
So do we understand respiratory acidosis uncompensated?
Yes, sir.
Yes.
Yes,
We
sir.
understand. Now let's take a metabolic problem.
Hello.
Yes, hello. Yes, hello. Can you ask your question? Oh, someone said hello. Who was that? Okay, maybe the person has gone off of it. So come back again. Kindly feel free if you don't understand anything so that we go over, okay? I want everyone to
Yeah,
understand this.
yeah.
Yes.
Flamingo, please, I don't understand.
Okay. Which side don't you understand?
The whole
So that I will
The whole
know.
show.
Hey, hey,
The whole show. I'm
Oh,
confused. I'm
a karma.
confused.
How many people want the whole show?
Please, me, the whole show. I
Madam
don't
Priscilla.
understand. Yes, sir. I don't understand.
Okay. Okay.
But
Madam
I
Priscilla,
also
let's
get
use this
lost at
question. Where? You got lost as well?
the
Okay, no problem.
you can the whole show once you are going over again.
Okay, so let's use this example. Let's use this example.
Your
The
line is
last
breaking.
example here.
Please, can you position yourself? Well, looks like
Your line
your
is
line
breaking.
My line is
Yes, it's breaking.
okay. Hello?
Hello.
Hello, sir. It's better. It's better
Okay, we
now.
can hear you now. It's better.
It's better. It's better.
Yes, sir.
Today
Yes,
I've
sir.
10 Archimedes. So
Yes,
my
sir.
line
It's
is
better.
messing. It's better. Okay. So we are using this example, the
Yes, sir.
last example. pH. So let us all do it together. Pick pen, pick a paper. Don't just watch. If you watch, you might not understand. Pick pen, write pH 7.23. So 7.23 is a pH. But carbon dioxide is 37. Carbon dioxide is 37. bicarbonate is 18. Now, let me take this again. I hope we all understand that pH, the normal pH, is between 7.35 to 7.45. Do we all appreciate this?
Yes, sir.
Yes, sir.
Yes, sir.
So if you have pH that is going towards this direction, more than, or pH that is less than 7.35, we call that as acid. And if you have pH that is more than 7.45, we call that as a base, or alkalosis.
Yes.
Or alkalosis. Okay.
Yes,
I
sir.
hope we all appreciate this one too.
Yes, sir. Yes, we
Yes.
do.
I'll come back to
We understand.
I will come back to the absolute pH, but let's do this one for now. Then I said that when you take carbon dioxide, normal carbon dioxide is between 35 to 45. I said that carbon dioxide in itself is considered as acid. So if something is considered as acid and the thing is more than the normal, then it means that you have more of that thing in the system, which means that the system is likely to be acid. I hope you also appreciated that.
Yes, sir.
So
Yes, sir.
if you have pH, so if you have carbon dioxide more than 45, it is likely that the system is acidic. And then if you have carbon dioxide, because carbon dioxide is acidic, if it is less than the normal, then the system is likely a base or alkalotic. So if you get your carbon dioxide and the carbon dioxide is less than 35, think about alkalosis or base. And then the last one will be bicarbonate. Normal bicarbonate, for the purpose of the NCLEX, we are taking 22 to 26. If it is, and then bicarbonate is also considered as a base or alkaline itself. So when you have more bicarbonate in the system, so base here. Then if you have less bicarbonate in the system is likely to be what we call acidic or acidosis. Now, if the problem is coming from what we call bicarbonate, we term it as metabolic. And then the other way around, if the problem is coming from carbon dioxide, we name what is happening as respiratory. That is what I want you to appreciate before we then go into the question I have kept there. So now let's come back to the question. So now the question, using the same method, you draw your lines, okay? Draw your three here. 1, 2, 3. Acid here, normal here, and the base here. Now, pH we are using is 7.23. Based on what we did, Madam Priscilla, the pH,
Yes, sir.
is it acid? Is it base? Yes, so
It's
I'm asking
acid.
you a question. I'm asking that based on the pH I have given, 7.23, is it acid, is it base, or is it normal?
It's acid.
is acid. So the
Yes,
pH will
sir.
fall under acid here. The pH will fall under acid here. Now, let's take the let's take carbon dioxide. Carbon dioxide is 37. We said that the normal is 35 to 45. Based on the figure here or the value here, is it normal? Does it fall under acid or does it fall under base?
Base.
It's
37.
base.
Normal.
Base.
It's base.
No.
It's
Madam Presley
normal.
again. Madam
It's
Presley again.
acidic.
One after the other. Madam Presley again. Carbon
Yes.
dioxide is 37 here. The normal is between 35 to 45. And I'm saying that, do you think the carbon dioxide is normal or abnormal? Let me then ask that first. The normal
So it's
is
normal.
normal. You sure it's normal?
Normal. Yeah.
You sure? Okay, so she says
Yes, it's
she's
normal.
Yes, it's
carbon
normal.
dioxide is normal. So it goes under normal. Let's take the bicarbonate. Bicarbonate is 18. I said that the normal is 22 to 26. And I said that if it is more than 26, it is a base. And if it is less than 22, it is acid. So, Madam President, based on what the bicarbonate, do you think it is acid, base, or is normal?
It's acid.
It's acid. So that is, it falls under acid here. Sorry, 3 rather. It's not 2. Now, so we know that the system is acid and the problem is coming from bicarbonate. And we said that bicarbonate is what? Is metabolic or is acidosis? Sorry, it's respiratory. Which of them? Is bicarbonate metabolic or respiratory?
It's metabolic.
Metabolic, right? So now to name this, you start from where the problem is coming from. It is a metabolic problem. So you start with metabolic. You start with metabolic. Then we know it is acid. So, or the problem, the system is acidosis. Then you bring acidosis. Then you now come to the other side. You come and look at the carbon dioxide. Is the carbon dioxide doing something to try to make the system normal or not? If it is trying to do something, if it is carbon dioxide is trying to do something, it will not be normal, it will be abnormal. But in this case, carbon dioxide is normal. So it means that carbon dioxide is not doing anything at all, true or false?
True.
So it means that it is not compensating. So we term it as what? Uncompensated. So you then add your uncompensated to it. Uncompensated to it. So now the final naming of this will be metabolic acidosis, uncompensated.
Okay. Thank you. Thank you very much. Understood.
Is it fine?
Yes.
It's fine. It's fine. Very fine. Babe, I'm coming.
Okay. Ask your question. Can we move on?
Yeah.
Okay.
Flamingo.
Yes, hello.
Please, so like I get the whole show, but when you are naming it, so you name it from where the acid is, like where the
So where
pH
the
in
problem is coming from first.
Okay.
Then you go to whether it is acid or base. So if it is acid, we say acidosis. If it is a base, we say alkalosis. Okay. Hello.
Hello.
Are you following?
Yes, sir.
Yes.
Then you come to the compensatory aspect, whether it is compensating or not. So we have done uncompensated scenario, about 2 or 3 of them. Let's look at compensation, whether partial. So we'll start with partial compensation. Let me clean my board. Okay. So by 7 we'll be done. I know that time has, but we had a lot to do. Now let's take, I want a compensatory mechanism. Okay, I have a compensatory mechanism here. Let's take the second example here. The second example. pH is 7.22. Carbon dioxide is 49. And then bicarbonate is 28. So now let's put our table here. I said acid here, base here. Sorry, the middle is normal. Here is base. Now pH is 7.22. pH is 7.22. Is it acid, base, or normal?
Acid.
Acid.
Acid. So pH will be here. Carbon dioxide is 49. Now we should be able to know whether it will be acid or base. So carbon dioxide is 49.
Acid.
Yes, acid.
Yes.
Acid, right?
Yes.
Yes.
Now, bicarbonate is 28. Is it normal? Is it base? Is it acid?
It's a base.
It's base.
Base.
It's a base because it's more than 26, right? So it comes here. That's HCO3 falls here. So now we know that the problem is acidosis. And the problem is acidosis, and it's coming from carbon dioxide. And we say if it is coming from carbon dioxide, we name it as what? Respiratory, right?
Respiratory. Mm-hmm.
Now, so let's start. Respiratory.
Acidosis.
Acidosis. Wait.
Compensated.
The compensated.
Compensation.
We have 2 of them. We have partial and we have full compensation or fully compensated. In this instance, it is partially compensated, and I'll explain why it is partial. Carbon dioxide, the bicarbonate, this time around, is doing something. Is doing something to try to bring the situation back to normal. But it hasn't been able to achieve that. If it achieved that, what will happen is that you see the pH falling within the normal, but pH is still abnormal. I'm saying that when it comes to compensatory mechanism, we have partial compensation and we have full compensation. In full compensation, pH should fall within the normal range, and the normal range of pH is what? 7.35 to 7.45. The pH should fall within this range for us to say that the system is fully compensated. But if the pH is not within the normal range, it is termed as partial compensation or partially compensated. Do we understand what I'm saying?
Yes.
Yes, sir.
So now we have been able to understand when compensation is taking place. Okay. Now, what I want you to understand is whether it is fully compensated or it is partially compensated. And I'm saying that it is partially compensated because the pH, even though the bicarbonate is trying to pull the system back to the normal, but the pH is still within the abnormal range. And so we say that it is partially compensated. So respiratory acidosis, partially compensated. Then you add your partially compensated to it. So now we've been able to name this one fully, that respiratory acidosis partially compensated. Is there anyone?
With you.
Is there anyone who is struggling here? We should take another example, right?
Yeah.
Yes, hello. Someone called me. Was it a question? Or the person wanted us to do more? Another question. Okay, I want another partial.
Please, let's take another.
Yes, I want to go through and see where there is partial compensation ongoing. Partial compensation. No, this is not partial compensation. This. I want partial compensation. I'm just going to.
Fall from the
Yeah,
bottom.
here. Let's take this example. Let's take this example. Let's take this example. Yes. So pH is 7.27. Bicarbonate is 33. So a carbon dioxide is 33. And then bicarbonate is 17. 17. Let's put them into our table. Here, we have acid here. We have normal here. We have base here. Right. Now, pH is 7.27. 7.27. Is it a base, normal, or acid?
Acid.
Acid. So we come
Acid.
here. pH is here, acid. Carbon dioxide is 33. Is it normal? Is it a base? Is it acid? 33.
Base.
So we have carbon dioxide here. Now let's take bicarbonate, 17. Is it acid or is it normal or is it a base?
Acid.
An acid.
Acid.
Acid. So you have CO3 here. So now we have been able to put this in our table. Now we are coming to name. So now we know that the system is acidic, right? And the problem is coming from bicarbonate. So we can start naming. So if it is bicarbonate, what do we start from?
Metabolic.
Metabolic.
Metabolic. Now we know that it is acid. So you bring your acidosis. Then you look at the carbon dioxide. The carbon dioxide is trying to do something. It's trying to compensate, but it hasn't achieved that fully because the pH is still not within the normal range. So we add what? Partial or partially compensated. Do we get it here? So this is metabolic acidosis partially compensated. So let me give you a tried one so that you guys will do that for me. Then I will not come into it. When you are done, I'll give you about, let's say, 2 minutes. Just do that for me. Then when you are done, you tell me what you had. Then it's just left with the full compensation. But the full compensation, I've taken 1 hour of your time, man. And so let's take this example. We've done this. Let me see this. No, I don't want this. Okay, I have other ones down here. Let me see if I could get another one here for you guys. Okay, so use this one. pH. Use the first one. pH is 7.31. And then carbon dioxide is 34. Bicarbonate is 21. The first one. Kindly use that. I'm giving you 2 minutes. If you are done, you can raise your hand up and then you tell me or you tell us what you had. And then you take us through how you got it. pH 7.31, bicarbonate 21, carbon dioxide 34.
Hello.
Yes.
I got
You,
metabolic acidosis.
you got metabolic acidosis.
Partially compensated.
Partially compensated. Would you like to take us through?
Yes, please. With a pH, you said pH is 7.31. So
Okay.
with that, it's acid. And with a carbon dioxide, that is carbon dioxide, right? That
Yes,
one
30,
is
34.
34. With that one is base. And with
Base,
a
okay.
with the bicarbonate, you said it's 21. That one is acid. So with that
Acid.
one, it's acidosis, right? And it's
Yes.
metabolic because of the bicarbonates. And with a carbon dioxide, it's not fully compensated because the figure is below 35. So that is why I got metabolic acidosis partial compensated.
So she said she had metabolic acidosis partially compensated. Is there anyone who also had the same, or is there anyone who had a different result?
I also had the same thing.
We all had the
Same
same thing.
The same thing, yeah.
Yeah.
Is there anyone who struggled to get the same thing as to what our colleagues are getting? Is there anyone who had a different thing? If you had a different thing, feel free and bring it up. Let me do fully compensated so that you understand full compensation. Then we drop the class here. Okay. So let me see if I have full compensation. If I have full compensation. pH. This, yes, I have full compensation here. The last question, we are using the last question or the last example here on the screen. It's an example of full compensation. Okay. So that you understand full compensation. Now, let's use the last one. pH is 7.39. Then we have carbon dioxide being 48. And then we have HCO3 being 28. Draw your lines. Draw your lines. Now, pH is 7.39. Is it normal or it is abnormal? That's the first point I want you to tell me. pH of 7.39, is it normal or abnormal?
It's normal.
Normal.
It's normal.
Normal.
It is normal. Okay. But it is normal. Even though it is normal, but it is not completely normal. I said that for pH to be completely normal, the figure should be 7.40. That is when we say the pH is completely normal, and we call that as absolute pH. So I use this line here, and I said that this is an absolute pH. We have 7.45 here. Sorry, 45 here. And then we have pH of 7.35 here. This is the normal pH range. Let me write this again. This is the normal pH range. But for us to say a certain pH value is completely normal, that is absolute normal, that value should be 7.40. If it is not 7.40 and it is within the normal range, which direction is it going? Is it going towards the acid direction, or is it going towards the base direction? If it is going towards the acid direction, the value should be between 7.35 to 7.40. It means that it is, even though it is normal, but it is leaning towards the acid direction. Are you guys following?
Yes.
And similarly, if it is normal, but it is more than 7.40, that means that it is going towards the base. Okay, even though it is normal, but it is between 7.40 to 7.45. If it is between this range, even though it is normal, but it is going towards more of what we call the base. So we say a base in that instant, even though it is normal, but it is considered as a base. And so that is where you think of partial compensation. So let's now come back to our example, pH of 7.39. Even though we have established that it is normal, but which side of the normal direction is going, acid or base?
Base.
7.39.
It's acid.
Acid.
7.39. It is less than 7.40. Okay, it is less than 7.40. So it is going towards the acid direction. Okay. Do we get it?
Yes, sir.
Yes.
So let's put our acid here, let's put our normal here, let's put our base here. So now we have established the fact that even though the pH is normal, but it is still towards the acid. So we still put it under acid. pH is acid. Now let's come to the second one, which is carbon dioxide. So this one is clear. Carbon dioxide here, is it a base or acid, or is it normal?
It's acid.
48, so it will fall under acid. Carbon dioxide here. Then the last one is bicarbonate. The bicarbonate is 28. Is it normal? Is it acid? Is it a base?
It's base.
It's base. So this falls under base here. So now we can name this. So let's start naming. So the problem is what? Is it respiratory or metabolic?
Respiratory.
Respiratory.
Do we all agree it's respiratory?
Yes, sir.
So respiratory,
Acidosis.
Respiratory,
Acidosis.
Acidosis.
acidosis. Now, this is where our compensation will come in. Now, I said that for you to have a full compensation, the pH should be normal. The pH should be within the normal range, but it should be towards a certain direction. And so in this instance, there is a compensation going on because you could see that the bicarbonate has increased, trying to like bring in more bicarbonate or trying to bring in more base. And in fact, it has been able to achieve that because it has brought what we call the acid, or it has brought the system back into the acid situation, or back to the normal situation. It has been able to compensate to the extent that it has brought the situation back to the normal range, but it is still towards a certain direction. That's why we said it is acidosis. So you look at the pH and realize that the pH is within the normal. And so because it is within the normal, we then say it is full or fully compensated. So this one is respiratory acidosis, fully compensated or full compensation. Let me give you an example for you to try for me. When I'm done, I'll put the questions on the page. You do them, you send them to me, and then I will look at it. So this will be our last example, then we drop our class here. Today, guys, I've done well. You've stayed with me for almost 3 hours. It's been a while I did 3-hour class. So let me see if I can get you a full compensation question. I think I have some here. Okay, so let's use this. So this is your question. This is your question. This is your question. pH is 7.37. Carbon dioxide is 33. And then bicarbonate is 18. This is our last question. Do it and tell me what you are getting. Then we can drop our class here for today.
Okay, I got acid to be pH for acid.
Okay, wait, so
Bicarbonate.
pH, so acid pH here.
Bicarbonate for acid to
Bicarbonate for acid. Okay, so CH3O.
and carbon dioxide for base.
Carbon dioxide for base. Okay. So naming, your final naming.
Okay, so the naming is the problem.
No, try, because you'll be able to put it on the table. So, I mean, where do you think the problem is coming from? Is it from carbon dioxide? Is coming from the bicarbonates?
Carbon dioxide.
No. Where do you think the problem is coming from? Is it bicarbonate or carbon dioxide?
Bicarbonate.
Bicarbonate, because the bicarbonate and the pH all fall under acid.
Acid. Okay.
So the problem is coming from the bicarbonate. So we said bicarbonate is what? When you are naming.
Metabolic.
Metabolic. And so we know it is acidosis.
Acid, so acidosis.
Fully compensated.
Fully compensated. Why? Because the pH is within the normal.
Within the normal range, yeah.
Within the normal range.
So fully compensated.
Thank you. One my
Do you guys understand?
Yes, sir.
So I'll put all
Yes.
these questions on the page. You can go through them, sit down. If you do and you have a problem, you can just reach out to me. I have questions, but just that our time is far gone. I would have gone through the questions with you, but I think at this point we've been able to do a lot. Yes, someone wanted to come in.
Yes, please, sir. Please, I wanted to ask about the partially compensated. So it means that whether the bicarbonate or the carbon dioxide is affecting the pH, in the sense that if it's affecting it to the 7.40, the optimal one, it means it's fully compensated. But if it's affecting it and it's still in the acidic zone of the pH, it means it's partially compensated. I wanted to
Yes.
clarify that.
Yes, so I'm saying that in partial compensation, the pH will not fall within the normal range, which is 7.35 to 7.45. If it is partial compensation, it will be either less than this or greater than this. But if it is full compensation, the figure should fall within 7.35 to 7.45. Then based on which side it is leaning towards, it will tell you whether it is fully compensated acid or fully compensated base.
Okay.
Are you getting the point here?
Yes, I get it clear.
You get it.
Thank you very much.
Okay.
Yes,
hello.
So one trend I've also observed is that once you are able to determine what the problem is, you realize that the other one that you think is not causing the problem is doing the opposite of the problem.
Yes.
Like in this case, once you determine that this is a metabolic issue, you realize that the carbon dioxide will also be doing something. The opposite of the issue. So if it's a metabolic acidosis and there's a compensation, you see that the carbon dioxide is also getting towards the basic side. And then if it's rather an alkalosis, you realize that the carbon dioxide, if it's also compensating, it's also getting into the acidotic side.
Acidosis, yes, will be increasing so that it will try to neutralize the situation going on. Is there anyone? Or last question. Let me see what this naming will be. This one is a random naming. So you just name this one and go. Okay. This one is a random naming. This one is a random naming. This one is a random naming. This question, just name this one and go. Just name this one and go. pH is 7.25. Carbon dioxide is 60. And then bicarbonate is 27. Name this one and go. We name this one and close for the day.
It will be a respiratory acidosis. Partially compensated.
Respiratory acidosis,
partially compensated.
Partially compensated. Great. Did we all get respiratory acidosis partially compensated?
Yes.
We all had that, right?
Yes, sir.
So we are done with
yes.
ABGs. So we are done with ABGs. Sefini.
Yes, sir.
Okay. So now when you get your questions, try and do it the same way we did it. Okay. It is not difficult. You just need to get understanding the basis, and that is all. Okay. So I'll drop my class here for today. It's been a very successful class. And so thank you for coming. And then sorry for me coming through today. Aki will come over next week. And then